Good afternoon, everybody, and welcome to our 14th iGeriCare live event. Today's topic is depression and dementia, and we are very fortunate to have Dr. Joel Sadavoy as our guest today. Dr. Sadavoy comes to us from University of Toronto. He's a professor in the Faculty of Medicine and the Institute of Medical Sciences at U of T, and is also the founding medical director of the Reitman Center for Alzheimer's Support and Training and the Provincial Enhancing Care for Ontario Care Partners Initiative, and senior clinical scientist at the Lunenburg Tannenbaum Research Institute at Sinai Health System. Dr. Sadavoy has won many awards in the field of psychiatry, geriatric psychiatry. He is the president of the International Psychogeriatric Association, founding president of the Canadian Academy of Geriatric Psychiatry, an active clinical practice, which, as we were saying, really keeps us grounded. Outstanding work with caregivers across the province throughout his career. And really an inspiration, has trained many folks in the field within Canadian geriatric psychiatry. So really pleased that you could make it here today with us, Dr. Sadavoy. Before we get into talking about depression and dementia, well, I wanted to ask you a little bit about some of the really innovative programs that you are doing in the province focused on caregiver education. Maybe tell us a little bit about a couple of those initiatives.
Sure, I'd be glad to. Thank you for having me today. Just one quick correction. I do not want to appropriate the role of the president of the International Psychogeriatric Association. I was, but I'm not now. So
fair enough.
Just in case the president is watching. I became involved with caregiving and development of programs in this area about 10 years ago when the Reitman Center was started. It's a program at Mount Sinai Hospital in Toronto, Sinai Health, that is devoted to creating and initiating programs for caregivers. We have basic principles that we've operated on from the beginning, which is that we want our programs to be as evidence-based as possible and address key issues that caregivers need to engage with in order to sustain themselves in this very difficult, sometimes burdensome role. The four areas of focus for us are, of course, to enhance knowledge that is specific to the caregivers' issues as they are at the moment, to help them guide through the complex system of getting resources and to act as a navigator for them. But perhaps most importantly, to help them address issues of emotions and learn the skills necessary to adapt to the new language and interaction that is necessary for dealing with dementia at home. So we deal with family caregivers in this regard.
And the I'm going to put up a few screenshots from the dementiacarers.ca website. And just for the caregivers watching this, what can people find at dementiacarers.ca?
So this is a treasure trove, I would say, of resource for carers. So the Reitman Center program, the basic program, is a group therapy intervention. And it is available, it's called Carers. It's 8 weeks, 2 hours a week. It's intensive, needs to be, to make change for caregivers. And it's available at the Reitman Center. In addition, this program is available throughout the province. Our program has been disseminated through what is called the Enhancing Care for Ontario Care Partners program. And it is therefore available at 12 locations around the province. We've trained people to deliver the program in those locations. So on this website, if you are caregiving for somebody with dementia and you need help, we are in partnership with the Alzheimer's societies in key locations. On the website, you can find the location of a program. You can contact that program, register for it. You can also find a whole array of learning resources Many of them are video-based and I think quite valuable. You can also learn about some other things like the applications we've developed. So our programs initially were delivered face-to-face. They are now all mounted on online platforms. So as you can see here, the CARES program, the 8-week program, is one that I mentioned. There is a 4-week program called Teach, and there is a telemindfulness program that's available. All of these can be accessed online. You have to register for them, and you can go through the relevant Alzheimer's Society. Some people may call us directly, and we would try to engage with them and enroll you into an online caregiver program.
The online programs, are they only available for people in the province of Ontario at this time?
Yes, they are.
But I guess one of the tools that I'm a big fan of is the Dementia Advisor app, and that is available to anyone across the country to download. Is that right?
That's right.
So maybe tell us a bit about that.
Sure. The app was developed based on the way we address things. So we do a lot of simulation and help people go through conversations about what's actually happening at home and help them to learn new ways of communicating. The app was designed to take people through 21 different scenarios, conversations essentially. It's interactive, and so you can learn how to engage with and deal with problems that are common in dementia. For example, resistive behavior or suspicious behavior, and to learn how to mold communication.
It's a fantastic resource and very practical. I think it walks people through, the kinds of things like what should I say in very common situations. So it's downloadable from either the iTunes App Store or Android.
Right, both Android and iOS. That's right.
Okay, well, fantastic. Why don't we start into talking about an important topic about depression. And while obviously depression is common in adults and children and adolescents more generally, let's start off with, I guess, a little bit about just a review of what we mean by depression when we talk about clinical depression, and say a little bit more, I guess, about depression in dementia as well.
Sure. So we all know, I think, that low mood, discouragement, demoralization is a part of everyday life. We get confronted with things and we have natural reactions like that. When those feelings take on, in a sense, a life of their own, they can slip out of being simply reactive and become a more intense, what is called essentially clinical depression. The nature of that is somewhat different than what we experience often, commonly throughout life. It is characterized first by a very deep internal feeling of a loss of pleasure, often loss of purpose. And while we call it sadness sometimes, it's a misnomer. This kind of depression is a painful state for anyone who has it. And people are in such pain sometimes that they can no longer tolerate this and contemplate ending their lives. Depression also affects not just mood, but physical function, sleep and appetite and energy and the speed with which we are thinking. So it can impair concentration and produce anxiety. And it also creates a feeling of worthlessness and hopelessness about both the future and oneself. So depression is a profound experience. In the elderly, it gets a bit complicated because some of the symptoms of depression are also associated with changes that are age-related, perhaps some increasing fatigue, some loss of activity, maybe some less availability of socialization and so on. So people can start to look as though they're tilting into depression when they are actually really just trying to cope with the changes and vicissitudes of later life. Dementia puts another layer of complexity in trying to understand depression. So in about 40% of cases of dementia, depression will be an accompaniment. Dementia has its own array of symptoms. There are many kinds of depression, Alzheimer's disease, vascular blood flow problems in the brain, other kinds of things you may have heard of, like Lewy body dementia. All of these are vulnerable to having depression accompany them. The trouble is that with dementia, a lot of the symptoms of dementia that go far beyond memory and cognition they overlap with what we might call depression. So, for example, anxiety and apathy are two very common accompaniments of dementia. These are also hallmarks of depression. It is very difficult for caregivers frequently to understand the difference, and commonly people will come and say, I think my mother is depressed, she's not doing anything, she doesn't want to go anywhere. And when we dig into that a bit and try to determine how she actually feels, there's no sense of any of the hopelessness or the loss of purpose or these feeling of depressive experience. Rather, the apathy feeling is one of a loss of initiative, a lack of interest or engagement, because of the brain, I think this is the reason, is no longer able to cope with all of the things that are going on. It tends to shut down a bit. And also because parts of the brain that are associated with actually taking action and initiative and motivation can be damaged and are often damaged in dementia.
So it sounds like depression is really quite common. 40% is very high rates of depression in dementia, but can sometimes be a bit challenging to diagnose because of the overlap in symptoms. What are some of the things that caregivers should look for specifically in their loved one if they're coming to an appointment and they are concerned that their loved one might have depression? What are some of the things that they might notice and maybe report to a health professional?
It's hard, I think, for caregivers to sort this out themselves. It is actually hard for professionals to sort it out. So there's the diagnostic process is a fine-grained, careful process. That's one of the things that has to go on. At home, the caregiver will become aware of a change in depression, in attitude, expressions of feelings of worthlessness. I can't do this anymore. I used to be able to do this. I don't want to live with this any longer. And often there is an accompanying array of emotions that are visible, tearfulness and crying. Someone came to me recently, husband and wife, and she had been diagnosed with dementia. And in that diagnosis, she saw the future as an impossible vision for her. She also felt that she could no longer do what she could do before. And some of the things that she was able to do mechanically, she was beginning to have trouble with. And she just melted down before she came to me as she was trying to do certain things that were automatic for her before. When she couldn't do them, she became intensely tearful and sad, and also had a sense of herself as no longer being who she was.
Will caregivers sometimes see maybe worsening of some of the cognitive problems or memory problems in dementia if the depression takes hold? Maybe a more sudden shift in some of their thinking.
So depression can herald dementia, sometimes even before the dementia becomes obvious. The depression symptoms can emerge. One of the hallmarks of depression, even in the absence of dementia, is impaired cognition. when dementia is also present, then the onset of depression can lead to, as you say, a sudden decline in cognitive function.
And we've talked about in some of our iGeriCare lessons this concept of pseudo dementia, and that refers to somebody with a depression so severe that those cognitive problems or memory problems look like dementia, but when treated. But I guess it can also affect the memory and cognition of those with dementia.
Yeah, I think that's overall, it is almost always the case that when cognition is severely disturbed in the presence of dementia, it is likely that there is both dementia and depression. And even when you treat the depression, cognition may get better, but the problems don't go away completely.
Now, we have talked about dementia being an umbrella term, and you mentioned there's a number of different causes of dementia, Alzheimer's disease, vascular dementia. Maybe say a little bit about the particular relationship between stroke, vascular dementia, and risk of depression.
It's been known for a long time that certain kinds of stroke, particularly left-sided stroke in the front of the brain, can produce quite serious depression. Beyond that, however, in all forms of dementia, depression is common. We don't know the cause of depression. We've got lots of theories, but one thing is pretty clear, that disruption of the circuitry of the brain and the chemicals of the brain is associated with depression. There is one form of dementia, which I mentioned before, vascular dementia. In this kind of dementia, there is a close association, close is too strong a word, but a very common association between the presence of the brain lesions, which you can see on MRI by taking a picture of the brain. You can see these brain lesions, and there is a strong association between them and the presence of depression. That kind of depression has been called vascular depression, and it probably comes from either a disruption in the circuitry caused by death of brain cells, or potentially from inflammatory processes in the body, which may not be obvious, but are also closely associated with depression. Same thing happens in cancer, for example.
I think that the take-home message for many caregivers is, if your loved one has had a stroke and may or may not even have any signs of vascular dementia, they may have just had a stroke, monitoring more closely for the occurrence of depression is warranted, and talking to your health professional should any symptoms of depression arise.
That's right. Yeah, there have been studies of prophylaxis, that is giving antidepressants prophylactically in stroke.
Well, actually, that's a good segue into one of our questions that has come in. So we'll maybe come back to some other things, but there was a question posted: can depression, which is not recognized or diagnosed immediately and treated, can it actually contribute to a more rapid progression of vascular dementia?
That is a very good question. It is one of those chicken and egg questions that is extremely difficult to answer. The relationship between vascular dementia and stress is, I can't be too categorical about this, but there is probably a relationship of sorts between those two things, given the fact that inflammation in the body may be a factor in inducing some of the vascular changes. So it is possible that the stress associated with depression may worsen the actual vascular dementia. I don't know of any studies of that, but it's, I think, theoretically possible.
I think we could say that if it's not recognized and the depression is going untreated, it would certainly run the risk of worsening the symptoms of the dementia. Whether or not it's actually changing the course of the disease itself. It would look like the vascular dementia was worse.
The reason I said what I said, for just that reason, is that often caregivers struggle with this concern that the depression is going to actually make the disease go faster. And people worry about the same thing with apathy. Yeah. If there's lack of activity or involvement, am I not doing my job as a caregiver if I don't get them moving? And is this going to make the dementia worse?
Well, we've been talking about depression in the person with dementia. We also know that the caregivers themselves are at risk. And this question came in from Mississauga. How common is it for caregivers to experience depression? And how does that impact on their ability to provide care to the person with dementia that they're caring for?
Right. It's an excellent question. Roughly 25 to 30% of people who are caregivers develop significant depressive symptoms. So this is a common phenomenon amongst caregivers, and it's one of the things that increases caregiver burden significantly. It's also associated with difficulties in being able to cope. I'm looking up from the camera as we talk, so I can see what the question was. So I'm really not avoiding you on
just
this.
How the experience of depression in the caregiver might impact on them caring for the person with dementia.
So caregiving by itself is it's extremely taxing, and the trouble with caregiving is it goes on for a very long time. When depression emerges, it can lead to all of the things that we talked about before: withdrawal, lack of energy, a feeling of hopelessness. Those feelings are run exactly counter to what caregivers need in order to be able to deal with dementia. You have to have your wits about you. You've got to have energy to do all the things that are necessary. You have to be able to engage and communicate. And depression actually is a serious barrier to being able to do all of that, as well as, of course, the pain that it causes the caregiver to be trying to cope and to feel this inner sense of not being able to function and sometimes not wanting to live. Caregivers are also vulnerable to physiological change and physical problems, and depression exacerbates that.
I think some of the things that we recommend for caregivers and caregiver wellness, like to try to socialize more. That's when caregivers are depressed, they often don't feel like going out. I think the other thing that we sometimes see, they may be challenged with people who are, have responsive behaviors. Their levels of irritability or their patience may be further taxed if they're suffering from depression themselves, making them much less tolerant and patient. So I think there's, again, the importance of recognizing the importance of caregiver wellness. And if you yourself are coming down with depression, to seek help and seek treatment, because it will definitely compromise your ability to be able to provide care to somebody else.
And I think it's important to say that caregiver depression is treatable and can be managed. So it's not necessary for caregivers to deal with this alone. Caregiver isolation is a major issue in dementia care. And when depressed, it can often feel as though there is nobody else there. But there is help, and it can be made available.
There was a question about whether there's a resource like dementiacarers.ca available outside of Ontario. I think almost all of the Alzheimer's Society branches across the country have caregiver education. They offer First Link programs, but I'm not sure whether there's anything quite like your carers program in other provinces. Are you aware of?
There are. We've had an opportunity to train people elsewhere. So there are programs in Calgary, Vancouver, Manitoba. I'm not sure if it's active in Nova Scotia, and we've also trained internationally, so there are programs in Vermont and in Israel and in Singapore.
Wow.
So if you're traveling,
Yeah, and
you can find them.
I think the experience and successes within Ontario, it would surprise me if other provinces look to pick up the carers program.
Yeah.
But so we have another. This is a story. Patients saying my father is in mid to late stage dementia, and actually having challenges remembering unhappy memories from the past. Thinks they're current things that are happening. He's unhappy. I guess his first wife had cheated on him, and he's bringing it up with his second wife, the person, the caregiver's mother, I guess. Are there any medication or counseling strategies that might be helpful for kind of remote, unpleasant memories that are coming up? He's also not currently on any antidepressants or medications.
Mm-hmm. So I guess the question is what's going on, and there are different possibilities. One is depression, but it actually doesn't sound like depression to me. It sounds like the difficulty that dementia produces in being able to track time change and to see things remotely that as though they are happening currently, and then reacting to them. Some of those things can lead to things like suspicion or paranoid behavior, to use the term. So in a case like this, if that kind of agitation is coming out of a suspicion, then there are potentially medications for that. If the agitation is more broad-based, just a kind of general difficulty in controlling feelings, there are other kinds of approaches with medication that may be helpful. None of them are highly satisfactory, I have to tell you. So it's really a trial and error. But some of the antidepressants, one of them called citalopram, may be useful in a situation like that, just for agitation. Depending on the level of the dementia and the capacity of the person with the illness to engage and talk about what's going on, because those capacities are lost as the disease progresses. But at certain stages, it becomes possible for the caregiver to learn strategies about how to engage and talk to someone who is engaging in this kind of unrealistic behavior. Usually the best way to do that is to tune in to the person with dementia's feeling. So rather than trying to correct them, rather than telling them that, that happened 20 years ago, to say, I can see how upset you are about this. Why don't we come over here, an arm around the shoulder, sit down, and let's talk about how, what you're thinking about and what, right? So not avoiding it and not pushing it away, and engaging with the emotion of the individual rather than the facts of the case, so to speak.
I feel like caregivers sometimes get different advice around some of these, and sometimes it's about, well, engage with the emotion, and other times the recommendation might be to try distraction or another activity. And I think that it goes back to what you were saying. It really depends on the stage of the illness and what the person with dementia is able to engage with. Are they able to, engage in that conversation about their feelings, or is there less traction to be had that way?
Yeah, there's a lot to say about every one of these issues. I haven't found distraction usually to be helpful. It's good for the caregiver, I think, because it settles things down. But that may not be the best way to promote an engagement between the caregiver and the person with dementia. Sometimes you don't want to do that because it's too fraught. There's too much agitation. But one of the factors in producing caregiver burden is a breakdown in the relationship, and the absence of interaction and connectedness can be very difficult for caregivers. So to the extent that there are strategies for enhancing that interaction, even in these moments of difficulty, then it can be helpful. Sometimes it doesn't work, nothing is helping, and distraction becomes a very important and viable option.
But the connection itself, even if it's around a difficult topic or emotionally challenging one, that connection itself, if the person's able to kind of meet one another, may also enhance the sense of being understood and the relationship.
Yeah.
There was another question actually about whether there's any kind of causal relationship between depression and dementia. I think it was worded about the link between depression and dementia.
Mm-hmm.
Can depression play a role in the actual development of dementia?
When we're in this murky territory of what causes what, you always get from us, so-called experts, the chicken and egg discussion. So there is a link between depression earlier in life and the vulnerability to developing dementia later in life. What we don't know is whether the depression is actually producing change that leads to dementia, or whether we're seeing an early process of dementia. So once dementia comes along, depression becomes very common. Prior to dementia starting, depression can be as I said before, an early symptom of dementia, even before real cognitive change occurs.
I think particularly in a patient who has gone through their whole life and only develops their first episode of depression in late life,
right?
That would be a bit of one of the warning signs.
That's right. Yeah, late onset depression is often associated with later dementia.
Here's somebody who's saying, I like what Dr. Sadavoy is saying, but how can I learn to do this? And I think that's speaking generally about reducing caregiver burden, but maybe also some of the other specific strategies that you're talking about.
Right. So there are different ways to learn how to do it. One way is to go to available resources. So, for example, if you go to the Dementia Carers website, as we said before, this is not an infomercial. I'm not trying to promote it, but the resources there teach how to engage and interact. They are very focused on these interactional issues, communication, and so on. That's one way of learning, but you have to do it and then adapt it yourself.
I'm just going to loan you my microphone while we replace your battery.
Sorry, I've run out of battery here. Another way of learning this is to see if you can seek out some of the programs that are available. The Alzheimer's Society is a very good resource. Sometimes they have programs that actually help to train and teach in this area. If you want a more in-depth approach to this, then there's no quick way to do it. You really have to go and gain the skills and training necessary. That's why the CARES program was developed. If you're in an area like Hamilton or Toronto or North Bay or Thunder Bay, or Sudbury, or there are a number of areas in the province, then the program is available to you. If you can't access it and you face-to-face and you live in Ontario, then you can get it online. And if you go to the website, you can find out how to register for that. And if you're having real trouble and you want information, then you can call the Reitman Center at Mount Sinai Hospital and we'll answer the phone.
Thank you. So, and I feel like if you're out of province, as you suggested, the Alzheimer's Society really covers most of the country. There's some online programs. We try to cover some of those strategies, at least some of the knowledge, in some of the iGeriCare lessons that talk about responsive behaviors and apathy and depression. So, but I think, as you say, the more immersive type of experience and really investing in the skills is probably going to need some of those more intensive programs.
Yeah. It's hard. Because caregiving is time intensive. It's hard to make the time. But the people who do it find that it's well worth it.
So another sort of follow-up to the question about the link between depression and dementia, is there any evidence that treating depression earlier might be beneficial?
In general, the earlier depression is treated, the better the results. And if depression is present with dementia, the better it's treated, the more control there is over the symptoms of dementia. So early treatment, when it's recognized, is a very good thing. It's not likely going to affect the course of the disease itself, although the complications of dementia are such that if it by itself can have a really deleterious effect on the health of the caregiver. So treating early. The nature of treatment of depression in dementia is a little bit different than it is for general depression treatment or treatment in old age. So treating elders can be very effective. Seniors are benefited from depression treatment, including antidepressants. Dementia adds a layer, and it's more difficult to address these. So antidepressants with dementia are commonly used. They should be used, but with caution, and they're not likely to be as effective. So there are some who I believe that psychotherapeutic interventions are better. We talked about vascular dementia before. That kind of dementia produces depression that has impairment in executive function. That is the ability to solve problems, to deal with new situations, initiative and motivation, etc. The way that psychotherapy has been devised for treating depression in dementia addresses that specific thing. So, for example, there is a program called PATH. It's called Problem Adaptation Therapy. And it is really a process of identifying what the person with dementia is having difficulty with, that may be producing demoralization in them, and putting solutions into the home. What might that be? It may be notice boards, it may be calendars, it may be active socialization, it may be bringing people into the home to engage with the person with dementia, because the disease is very isolating. It may be thinking about what is pleasurable for the individual, and music therapy has been one of the things that has been sometimes quite helpful. Indeed, the Alzheimer's Society has had a program where you can actually get music in an iPod, take it home, and use it. So there are a number of strategies, sort of psychotherapeutic strategies.
So, this is another statement from a caregiver who's experiencing the challenges. I definitely, as a caregiver, have depression. Looking after my wife who has Alzheimer's has become overwhelming for me. I know I need help, but confused on what are the first steps to try or place to visit for help. We're both getting worse fast.
Right. The most effective, the most rapid access to the healthcare system is through primary care, through the family physician. Family physicians may or may not be able to provide frontline treatment for this depression and help. If they can, then in the family doctor's office, you can begin to get treatment on the spot right away. But it means going in and really being able to describe and identify what it is that you're experiencing, so that the doctor has a real sense of that. Sometimes you got to slow the process down and really tell your doctor you need to take just a few minutes to tell him what's going on. The next step in the pathway will likely, or often, if it's complicated, will be a referral to a mental health professional. And those resources are available in the system. Family doctors should have knowledge and access to them and be able to guide. At that point, the probability is that there will be a more in-depth discussion about what's happening and a determination of what might be the most effective interventions. Often medication can be very helpful in these circumstances, but it's not the only thing.
And it may be that in the meantime, there's some practical solutions. Depending on where you live, the jurisdiction, there may be some kind of additional home care supports. Maybe this is somebody who needs a bit of respite even to focus on their own depression. So whether that's a day program or home care supports to allow the caregiver a bit of respite, even to focus on their own depression and well-being. So there may be some other very practical approaches in addition to seeking out help and treatment within the healthcare system and the mental health system.
That's true. Respite is one of the top first things on the list, I think, for caregivers. They often want some relief. The problem with respite is that it's time limited, and it's sometimes hard. For example, to bring somebody into the home where there's a lot of resistance. People don't want people in the home. Person with dementia doesn't want babysitting. There are a lot of problems with that. So it's not that respite isn't essential and necessary, but it can sometimes be frustrating for caregivers when we have prescriptions for them, as we all do. Our programs are prescriptive in some ways, but these prescriptions are not always realistic for caregivers, and it can be very frustrating to hear advice, whether it's from friends or family or others, that doesn't really tune in to the specific situation that you're dealing with.
A couple of other questions. Could you please provide info on the effects of antidepressants or mood stabilizers on patients with dementia? How do you monitor the effectiveness of medications on patients with dementia in a long-term care setting?
So long-term care is its own environment. The monitoring of clinical care in those settings usually flows from the frontline practitioner, the PSW, to the nurse on the unit, to the doctor who is making the prescription. Sometimes in very good units, there is expert help with psychiatry, consultation, and so on. If there's a severe issue with management of medication, then often the involvement of a consultant can be helpful. The monitoring of antidepressants is in two parts. One is, are they producing side effects? And the second is, are they producing an effect? And the monitoring of effect is really looking at the target symptoms that need to be addressed with this medication and seeing whether they are improving. That requires a set of knowledgeable eyes on the process. Experienced family can sometimes see it themselves. The mood stabilizers are another category of drug intervention. The problem with dementia and depression is that the use of medications is often complicated by the vulnerability of the person with depressive symptoms and to side effects.
I think we can safely say that there's really not a lot of good evidence for the mood stabilizers in the management of either responsive behaviors, agitation, aggression in dementia, nor is there really a role for mood stabilizers in the treatment of depression. So the reason why the mood stabilizer was chosen in this case might be related to a different condition, like manic depressive illness, or perhaps it was a Hail Mary to help with agitation, which I think is something that we often see. People are rather desperate, so they will try a number of different classes of medication, but as you said, the side effect burden may be high, the evidence may not be so compelling.
It's true. And it's hard. It's hard for caregivers in long-term care because they can feel quite helpless in these situations.
Well, and I think it's very hard sometimes for the professionals as well. And as you say, the best case scenario is probably those contexts where there's often a house family physician or a house doctor where they would hopefully be able to access specialist consultation around the monitoring of the medications. We have a few other questions. I think we have time for one more. This is a complicated one. Family member with moderate dementia, been depressed for some time, depressed about his decline, so has, I guess, some insight. Possibly coinciding with sundowning, he gets very upset and agitated in the afternoon. Staff at his PCH, home, don't know, give him risperidone, but this does not alleviate his acute distress. What seems to help him most is distraction, but there aren't enough staff to help with that. He's been tried on a number of other medicines, sertraline, mirtazapine, citalopram, escitalopram, so all antidepressant medicines with no benefit. Are there any other medicines that might help? It's horrible to see him suffering. And are there any behavioral therapies that could help?
It's an abstract question is hard to answer because the nature of the agitation and the precipitants for it are sometimes quite relevant. So there is what has been called an ABC approach to agitation. That is, what is the antecedent that precedes a change? Sometimes it just happens and it erupts for no reason. Sometimes there are reasons. The second is, what is the behavior? And then what are the outcomes? So in looking at the agitation, a first question is there something that is precipitating this? Frequently, agitation interacts with the contact with other people, which may be optimal or suboptimal, and lead to problems. Sometimes agitation is just part of the disease process. It's a release phenomenon. And so in the abstract, it's very hard to provide a formula, but observing the behavior, developing approaches to engage, including distraction, finding alternative activities during those times that may be helpful, soothing activities like music or massage with lavender. There are studies that suggest that may be helpful. So physical contact, warmth, different things for different people, different strokes may be helpful.
And that behavioral approach is really one about monitoring that almost systematically, looking to see if there are patterns that might suggest the best approach.
But you need cooperation from the facility in order to do that. It's not always available in every place.
Well, this has been a fantastic 45 minutes. I want to thank Dr. Joel Sadavoy for joining us today on the live event and for your participation and all the great questions today. iGeriCare was developed with support from CABI, the Center for Aging and Brain Health Innovation, powered by Baycrest. We've also been fortunate for contributions from the Jerris Center at Hamilton Health Sciences Foundation, our local Alzheimer's Society, the foundation of Hamilton Halton, and our team at the Division of E-Learning Innovation. As we know, teamwork makes the dream work. And we do have a survey at the top of the live event page. This is your opportunity to cast your vote for future live event topics. And we'll also post a few of the URLs that we talked about today, the dementiacarers.ca and the relevant iGeriCare.ca lessons, and link as well to the Dementia Advisor app. So I want to thank everybody for joining us. We'll be posting a copy of this for future viewing as well, and we'll see you next month.